Let me introduce myself. I'm Sue Hayward-Giles. I'm one of the assistant directors in practice and development, which is the professional body arm of the CSP, or membership organisation. And I'm very pleased to be chairing this event tonight. I've got accountability for the First Contact Practitioner Programme, accountability within the CSP to the leadership team and to council. So I'm really pleased to be here tonight. So before I do further introductions, let's just have a look at the agenda and let you know what to expect tonight. We have two presenters, Nick Worth and Hannah Morley. Both have done pre-records just because there are various issues, particularly because Nick is actually on holiday and wasn't entirely sure of his connection. So I have to say an incredible thank you to you, Nick, for joining us tonight. Hannah has done a pre-record, but unfortunately she's not able to join us. And then other CSP staff who are going to be present answering questions and on the panel, Abby Henderson, who most of you will know, who is our head of First Contact programme at the CSP, Mayana McDermott, who's the FCP programme coordinator, and most of you I'm sure will have come across May. My colleague Jill Rawlinson, who is another of the assistant directors in practice and development, who has responsibility for education and workforce, and Julie Blackburn, who is our Northwest professional advisor, but is also one of the FCP programme team. So thank you all for joining us tonight. In a minute, I'm going to ask you to take part in a poll. We would like to know a little bit more about you. So I'm not going to particularly share the results of the poll because it's really to give us some context to who you are, who's asking the questions. So there'll be a poll with 4 questions at the beginning. There'll also be a poll at the end, and I would really encourage you to please participate in them, particularly because one of the elements is whether or not we've hit the spot, as it were, tonight and managed to support you with some of the roadmap challenges that you're facing. So before we go into that poll, I just want to say a couple of things about tonight and about the roadmap. I think it's very difficult when you're being faced with a number of challenges to remember the bigger picture. And of course, the bigger picture is that the CSP and members, so we and you, both welcome the roadmap. We want that standard for education for practice in place, but that isn't to say that we're not aware of the challenges that it faces, and particularly for you in being directly employed, we know it has some unique challenges for you. One of the challenges that we did know about was about the time frame, and that wasn't just for you as directly employed FCPs, but it was across the board really. So we've got a close relationship with HEE. We talk to HEE, and many of you will also give feedback to HEE, and as we now know, the April 2022 timeframe has been lifted, so hopefully that's provided some relief to you. So tonight is going to be focused particularly on the supervisory aspects and asks of the roadmap. So both Nick and Hannah's presentations are going to be particularly about managing those aspects of the roadmap. There is a Q&A function on Zoom, who I'm sure most of you will be familiar with that now. So please do post your questions as the evening goes on. After both the presentations, I will open up to the panel. So we will answer some questions in writing as we're going through, and we'll bring some of the questions to the panel for further discussion. So please do use the Q&A for questions. You will see in the chat function that there are going to be some resources cut and pasted into the chat function. And if you have come across anything yourself, links that are useful for peers, for colleagues, please do use the chat function to support your peers on this call for that. May, could we go into the poll and let's just find out who's in the room? So there are going to be 4 questions. So we'll just give you a minute on the first one. May, if you can see the results, just...
Yeah, I'm just seeing, just give me a couple more seconds and then I'll end that one now and I'll launch the second one. So this one is about, have you secured a roadmap supervisor yet? Great, can see those answers coming in. That's really good. And that one. Third one is around the completion date, and just if anyone has locally agreed a completion date yet, given the deadline has been lifted. That's great, thanks. And then the final one before we start. This is just about confidence in understanding the requirements of the roadmap. These are all anonymous, by the way. Great. Thanks, Sue. That's all of them.
Thank you. So just to remind people, because people were coming in when I was doing a bit of an introduction, so please do use the Q&A function, not the chat function, to ask questions that you want the panel to attend to. Use the chat function for sharing any links that you think will be useful for peers. We won't be taking questions immediately after each presentation. We'll just be taking them straight to the panel, which we'll come to at the end. So without further ado, I'd like to introduce Nick Worth. Nick currently works for Health Education England as the North West Supervision and Assessment Lead for the Faculty of Advancing Practice. And Nick is also a national trainer for the roadmap. Nick's background is in professional football, and Nick has taught on several master's level courses and is a fellow of the Society of Musculoskeletal Medicine. And he teaches on injection therapy courses and independent prescribing courses. And as I said before, we're absolutely delighted to welcome Nick. He will be joining us on the panel. He's on holiday, so he did his session as a pre-record, but will be speaking to us live later. So thanks, May.
Welcome to the Supervision and the Roadmap session. My name's Nick Worth. I'm the Northwest Regional Supervision and Assessment Lead within the Faculty for Advancing Practice within Health Education England. I'm MSK Physio by background, and I'm also one of the national trainers as part of the supervision training. And I'm also a fellow of the Society of Musculoskeletal Medicine. So I've been involved in disseminating the roadmap over the last few months. What we'll talk about within the session today is go over the roadmap, and in particular with a view on supervision, and hopefully there'll be some hints as to what you can help you out with finding supervision, and then I'll be around for a live Q&A afterwards. So what's it all about really? Well, the roadmap to practice was released towards the end of last year. And it's really about understanding what the focus is of this document and where it impacts upon our practice. And I think understanding that and taking it back to basics is really important. And it may be something that you're obviously well aware of, but understanding that gives a context of exactly what we're trying to do with this. The first thing is about patient safety. By being able to offer a level of standard of practice, this is about ensuring that patients are treated appropriately in a safe manner by competent clinicians. Really, it's a way of being able to demonstrate competency and capability as a first contact practitioner. And that just means that under normal circumstances, a lot of the time when people have already been working in FCP roles, one of the comments is, well, I've been doing all right. There's not been any problems for me over the past. But what we're saying here is when you've been a clinician with a patient in a closed room, no one's really been able to see that you're still consistently working at a suitable level. And really, this roadmap is hoping to ensure and be able to monitor that you're working at the capability level that's appropriate for you and gain the support to be able to develop as things progress. The other side of it is it's often used, or one of the things I've heard mentioned is about that, we're just a cheap way of getting around doctors and it's about saving money. But it's about supporting the whole healthcare workforce. And in particular with that, what I would say is it's about patients being able to access the right clinician for the condition at the right time. It's not just about saving money. That may be a part of it, but the main thing is about that patient safety and making sure they get the needs that's required. And realistically, for me, one of the important things I've had when I've been speaking to clinicians all over the UK regarding this, it's about understanding what you're doing and what you're doing it for. Firstly, if you're a treating physiotherapist who enjoys the diagnostics and then the rehabilitation and treatment of a patient, then don't feel embarrassed that being a physiotherapist isn't enough for you. If you're a treating physiotherapist, and it's horrible to use the term normal, but if you are one of the normal physiotherapists that enjoys that role of managing people to get better, then that's fine. The FCP role is a different role and it's within primary care. So if that's not your aim, be happy to be a physiotherapist and be proud of that. From my point of view, I'd certainly regard myself as being proud to be a physiotherapist. Also, that first contact practitioners is an end in itself. Although the roadmap has 3 stages, you don't have to go through every single one. And I think the idea is that as an FCP, if you only want to be patient facing, so you want to have that challenge of complex cases as a first contact, you can be patient facing and then just stay within stage 1, and then stage 2 would be your supervision on a regular level. You could stop there. If all you want to do is treat patients, that's fine. The third side is that advanced practice and the APP level or stage 3 isn't compulsory. You can do it if it's appropriate for your service, but also if it's what you want to do. The point is the fact that it's a development opportunity for all. So I think sometimes people have got really worried and confused about, I have to go on the roadmap, I have to go all the way through. But actually understanding that you don't have to enter it at all if you're not in primary care. Also, if you don't want to be a first contact practitioner, as a physio, that's fine. If you just want to be patient facing without all the management and research responsibilities, FCP is enough. If you want to become an APP, it is open to everyone. And that's really what it's about, understanding where you are and where is appropriate for you. Also, it's about understanding the why. Why are we doing it and what's it about? So usually in the traditional model is the fact that a patient comes in with some sort of query or injury. They tend to go to a GP. The GP often might say, okay, wait for 6 weeks, see what happens, because they're not musculoskeletal experts. They're very general because it's general practice, but it's about understanding that their remit is to make sure that there's nothing serious going on. That may or may not involve medications, and then potentially it's a review if 6 weeks if things haven't resolved. As a first contact practitioner, what you're doing, and this is where it's different to a general physiotherapist, is you've got that ability to take someone off the street that may be a musculoskeletal problem, and you're then going to make the decision on what they're going to do. Now, you might find that that is watch and wait. That's perfectly acceptable if you've done that diagnosis and evaluated. But also, it might be that you're giving them some exercises or purely education. And again, that might be enough. It might be that you're sending them for some sort of imaging, potentially if you're a prescriber to deal with the medication, or it's rehabilitation or on referral to what I would say would be a normal physiotherapist. But also, being a first contact practitioner, one of the important things is understanding that you can get anything that comes through your door. So that basic shoulder problem that's turned up as a frozen shoulder may be, lung problems. It could be bony metastases. And understanding that then allows you to refer into a medical practitioner or other practitioner as required. And it's understanding that it's different, and the fact that you're opening you up to anything that can come through the door really is why there needs to be the standards and protocols in place. And that's where the roadmap helps. And that also is where your supervisor will help to ensure that you're working at the right level with the right support. And hopefully at the end of it, all we're trying to do is make sure that we get a happy and let's say resolved patient throughout it all. So understanding that and keeping that in mind all the time is really important. I think sometimes people have been frustrated that it's another hoop to jump through. This is all essential. It's just extra work. Remember why we're doing it, and the fact that in that FCP position, you might be able to be the person that finds a serious neurological condition or spinal metastases. You've got to have the capabilities to know that you're going to be seeing the right patient. This slide is really just a summary that I've put together, and it's been useful to share with different people just to understand the 3 stages a little bit, and also understand where supervision comes into it. So stage 1 is ideally, the plan is before you work in primary care, you do your e-learning modules and either taught HE accredited master's level course, or you've got a portfolio that's signed off by your supervisor. That leads you being onto the HE directory. Now, at the moment, that's still a work in progress. That directory isn't public facing as of now, but it's in process. And understanding you need that supervisor to be able to understand that the level of work you're doing is at the appropriate stage. Stage 1 and 2 is the clinical pillars, with stage 3 being the other 3, and we'll come on to that in a minute. Stage 2 is to having regular supervision whilst working in primary care. Again, this has been something that I've found there's been a lot of confusion about, is about people trying to rush through all the stages because they felt that there's a pressure and they're going to lose their jobs if they're not stage 3 by April 22. Supervision is about a process. Think of it like a patient. You see a patient, you diagnose, you put a management plan in place, and hopefully that resolves their problem and you reevaluate later on. Supervision works the same way. With supervision, you assess where you are, maybe through a learning needs analysis. You put a plan in place to understand and work on some weaknesses or areas of development, and then you reassess that in time. Don't rush that. It's about a process of evolution and learning, and that's what we're all trying to do. And then stage 3 is about understanding that you're working at master's level across all 4 pillars consistently. It's not enough to do one little research project a month. One little research project a year. It's about showing that you're working across the board, and that's what advanced practice is about. Just very quickly, a few key details. So the idea is stage 1 should be completed prior to starting in primary care. But at the moment, we will understand that there are a lot of practitioners with a lot of experience that are already working there. What we're working on at the moment, if you like, is kind of backdating and making sure that everyone who is currently working as an FCP in primary care is competent. And that's the stage we're at the moment. And this is going to take time to come through. Supervision is required throughout all stages, and the supervisors need to have completed either the supervisor's course from HEE, or they're either GP trainers or educational supervisors. At the moment, there's a push towards getting a lot more on board. So this is going to take time. So bear with it, because this is a work in progress. So stage 1 and into the stage 2 is the clinical pillar only. That's only the bit about showing you're working at a master's level. You've got that understanding about complex patients, red flags, yellow flags, that type of thing. To achieve stage 3, all 4 pillars, the education, research, leadership and management, needs to be consistently working at master's level. And that's why the supervision will be monitoring it over a period of time. It's not just coming and going a little bit. So the other thing with that is no need to rush. There was the deadline for stage 1 for existing primary care to be April 22, but that's now been removed. And that's quite helpful, because there was a sort of anxiety involved with getting people trying to rush through, or employers pushing people into, and it causes extra pressure. I've heard of people thinking of retiring or leaving early because of this. The reality is there's no need to do that. If you are currently working at that level, this is an opportunity to show that you are working there and you have the competency to be able to do that. A portfolio is being developed, but it's not ready for going to market, if you like, yet. So if you are gaining experience, keep that to one side, because it will be important. And realistically then, once you've achieved your stage 1 and you're on the HEE directory, you'd be looking towards moving to stage 2 within 6 months of completion of the stage 1. Regular supervision is not really something that's familiar in a lot of medical settings. A lot of doctors have it as a standard contract. But what we're trying to do here is this isn't only about if you're training or as part of a program of study. This is about regular supervision, work-based placed assessments or COTS, so clinical observation tools, etc., becoming the normal. We all need that bit of support. We all need that ability to prove that we're still working at an appropriate level. And this is where supervision is vital. But we really are starting things off here. It's going to take years to develop. So take your time, be patient with it. And really, the more we can work towards getting supervision for us all, that's where it's going to be really important. So how does it all work together and where is everyone fit with this? So let's assume that at the bottom right-hand corner, this is yourself. So you're sort of going, well, I understand there's a roadmap. How does it work together and where can I get supervision? So the roadmap's been developed by the Centre for Advancing Practice. And sitting at the top of that is Bev Harden and Richard Collier. Now, people, for example, like Amanda Hensman-Crook and Julia Taylor, who've developed the roadmap alongside a lot of others, they work for the Centre for Advancing Practice. It is somewhere that's virtual. There isn't actually a building for that. But the idea is that they are pushing advanced practice across multi-professions. And we're obviously talking about physiotherapy this evening. They've developed 7 regional faculties for advancing practice. And that's the area that I work in. There's a faculty lead, supervision and assessment lead, and project lead in every region. And they're being included with a lot of administration staff and other staff. So your region will have a faculty for advancing practice that can help support you. In terms of FCP training, and certainly the supervisor training, that's now been devolved a little bit to the regional training hubs. These are organisations that sit to help support training, again, multi-professional. It's not only MSK or physiotherapy, but they're the resource now where you'd be able to find supervisors. And I'll give you some tips about that in a few moments. They will help support your supervisor, which will then obviously be able to supervise you right the way through the roadmaps. The document that support that was written at the end of last year, authored by Deborah Harding, and a copy of that is shown there. But if you Google that, you'd be able to find out about what supervision looks like. And again, that's being evolved into understanding what happens within the roadmaps. So if you're looking as a supervisor or what needs to be included, all the details are within that document. So one of the challenges is, where do I find a supervisor, particularly if you're directly employed by a PCN? Well, the first thing would be is to ask your employer. Depending on where you work, there may be either GP trainers or educational supervisors that work within there. It might be that they're a different branch of a PCN, like a different surgery that might be able to support you. There may be other people within a trust area or even a location that might be able to be used for this. The other thing would be is to ask colleagues and friends, because quite a lot of the time within the physio world, as a network, there's a lot of opportunities to find out who's done the supervision course. At the moment, I think currently there was around about 450 supervisors who had been trained within England. That's up to the beginning of July. And that number is going to be increasing. And those courses are now shifting from being involved with support groups like APPN, MACP, and SOM. And that's now moving to being regionalized, because each regional training hub has a target it has to meet. So the next thing is to contact your local training hub. Now, simply with that is a Google search of HEE Training Hub will bring you up with this page. I appreciate that picture may be fairly small, but that's a landing page for all the training hubs. If you scroll to the bottom of that page, what you'll see there is where it says regional and local office contacts. That has usually email addresses, but sometimes phone contacts for every region. So if you're struggling and thinking, I don't know where to find a supervisor, there's not one within my PCN, contact them. They will be developing a list of supervisors in your area that might be able to support you. So it may be someone that works in a different company or a different PCN nearby, and it's a good networking opportunity anyway. Also, you've got the regional faculty for advancing practice. So again, through a simple Google search, we'll find your local one. And if you contact them, although they're working more in advanced practice rather than FCP, they will be able to put you in contact with the right people. So really, what will a supervisor do for you if you're a clinician and you're an FCP? So the idea is it's a range of things. So there are sort of clinical observation tools, work-based placed assessments, lots of that type of thing, where people will be testing competency and capability through a load of formal means. They'll also be able to verify certificates and portfolio advice. They'll be able to guide you to complete you to stage 1, and then be able to support you with your ongoing, for example, mandatory training, identify areas where you may need to develop, and be able to support you for your submission into the HEE directory. Very soon, there's going to be a supported portfolio route, which is going to be like a minor module that some universities may offer as a way of being able to obtain advanced clinical practice. So that might be something to look out for in the future. They'll do learning needs analysis to understand your strengths and weaknesses and be able to support your learning opportunities. That may be within house, might be external courses, or just might be, by shadowing another clinician locally. That might give people the opportunity to understand about what learning is needed and be able to support it. Like I said before, supervision happens over time. Don't expect it to be a tick box exercise. Yes, you might be able to demonstrate it on day 1, but can you do it consistently over a 6-month period? That's why I'm saying take a step back from rushing. This is an evolution and a development process. It's not going to be done all in one day. Take your time. Look at this as a consistent work in progress. And by doing that, hopefully it takes away some of the anxiety, but also shows you what we're doing it for. It's about making sure that we're consistently able to deliver a good quality, safe service. And the other thing that really shouldn't be sort of underestimated is the debrief sessions and pastoral support. So what I mean by that is the fact that actually mental health, dealing with timekeeping, looking after each other is really a good important part of things. It may be just having a coffee and a chat at the end of a session. It might be dealing with complex patients or going, do you know what, maybe I should have done that better. But these are all a part of the supervisor's role. So don't underestimate it. And although that may not always be formally written down, it's important to remember these to be included as part of your supervision. Just a few little bits and pieces from supervision that often gets asked. Well, who can be a supervisor? Well, you've obviously got people who are usually have done a postgraduate master's. They can apply to be a supervisor because that's normally been the criteria that all of the special interest groups have been delivered recently. If you've made it into an FCP or an AP on the register, on the directory, then you can. But it also can be a GP educator or trainer that is within your trust or your PCN. Where can you train to be a supervisor? The courses have recently been, or up until now, have been sort of really pushed hard by APPN, MACP, and SOM. That's now being moved regionally into the training hubs. So again, if you're wanting to know where to do it, they have targets regionally to be able to go to. So if you feel like you could be a supervisor for your PCN or your colleagues, training hubs are the place that you'd be able to find out all this information and when they can be delivered. Can supervision be done remotely? Yes, it can. Ideally, there obviously needs to be some sort of face-to-face and collaboration, but there are aspects that can be done remotely, and understandably in today's world, that there might be debrief sessions that would happen on Zoom or Teams as opposed to doing face-to-face. But there also are times that it's important to sit down with someone, because I do think there's that personal relationship connection that does make a difference, that maybe allows people to open up a little bit. Can you have more than one supervisor? Yes, you can. Ideally, you would try and have not too many, because that may confuse things. But if the supervisors are of a suitable level in terms of they've done the right criteria to become a supervisor, either doing the HEE supervisors course or they are a GP trainer, yes, you can. And then it's about documenting that and keeping that to one side to be able to evidence your ongoing supervision. What happens if things go well? Obviously, your first port of call would be your supervisor. Potentially, if there are an issue that you're really, for example, a relationship breakdown, illness, or something can't be carried on, you may be able to speak to your line manager or your employer. Again, if something's happened with the supervisor, there's a breakdown in communication and things can't happen, maybe an alternative supervisor can be found by going through your training hub, or alternatively, emailing through the Faculty of Advanced Practice. It does seem a lot of work. What's the point? I would always still find the biggest thing you really need to keep an eye on is what we're all doing it for. This is about making sure that as physiotherapists or as first contact practitioners, we're delivering safe, quality support for patients and being that port of call. If a patient comes in with something that is a masquerader, you need to be able to feel comfortable that you're consistently up to speed, that you're keeping updated and you're ready to be able to do it. It does seem like a lot of work, but it's a way of ensuring safety and practice. And it's the kind of thing that a lot of other professions do anyway. I think for us this is an opportunity to show that you are competent and you're really good at your job. So definitely it is an important thing. And remember, the patient at the end of the day is what we're all here for. So just a few bits and pieces. Where can you find out about this? This may be a screen that you decide to take a photo of. So the first link there is the roadmap homepage. What I would make sure with that is the homepage is updated on a regular basis with any kind of developments, recordings, tips and hints, maybe courses. So that's a really good place to be. The second link down is about the training hubs. Again, that will be able to explain the work of a training hub and where supervision may be able to be contacted. The last one there is the CSP pages, which are all about first contact physiotherapy. Again, if you go to the CSP pages, there's a lot of really good information that will be helpful to support you through your first contact physio journey, through stage 1 and potentially onto stage 3. Thank you very much for listening. I hope that's been of some use to you and hopefully clarified some of the concerns you may have. I'll be available for a live Q&A a little bit later on, and feel free to ask any questions. Thanks very much.
Just while we swap, thank you, Nick, for pre-recording that presentation. And just remind people while we're getting Hannah's pre-recorded presentation up on screen that you can go into the answered questions. You'll see that there are 3 tabs at the top of the Q&A. So please do go in and have a look at the answered questions. The ones that we're leaving as open will take to the panel for some discussion. I think where Nick started off reminding us about the broad aspiration and purpose of the roadmap, I think is really useful. I think it's sometimes really tricky when you're faced with a new thing that you have to do, to do that stepping back and just thinking, what is this about? And Nick's emphasis about taking your time with it, particularly now that the timeframes have been changed, I think is really essential. And thinking about your career, internally at the CSP, we've had quite a lot of discussion recently about people's career pathways, and just an important reminder about you making active choices about the roles that you go into and the infrastructure and support around those roles, and just taking some time to consider them. So remembering that broad purpose, I thought, was incredibly useful. May, are we okay to go to Hannah's presentation? Thank you. So Hannah Morley is a first contact physiotherapist, and she's an FCP service lead from Gloucestershire. Hannah is also a professional advisor with responsibility for Wales at the CSP. So Hannah has a background in MSK and pain management, and has conducted research into advanced practice physiotherapy internationally through a Churchill Fellowship. So I'm really pleased that even though Hannah couldn't be with us tonight, she's been able to contribute through this pre-record. Thanks, May.
Having a good evening. I couldn't be with you live tonight, so I'm joining you a few days prior on pre-record. But I'm here to tell you about my experience as a directly employed FCP. And really one of the messages is about being direct, and also being planned, having a good plan in place. So just to give you a bit of background, my name is Hannah Morley. I am currently an FCP lead in Stroud Cotswolds PCN, where we have 2 FCPs. We're recruiting a 3rd. I'm also a professional advisor with the CSP. My clinical background is in MSK and pain management, and I've been an FCP since 2017. So the service that I currently support in Stroud is an active service in 3 out of 5 practices. We have 5 practices in the PCN. And we're currently, like I said, increasing our capacity to make sure that we can get 5 practices out of 5 in the PCN with an active service. The positives of this area are that we've got a really engaged GP mentor, and our PCN directors are really engaged with the service, very supportive practice managers, and the GPs are sort of open to change and development. The difficulties, the challenges are that we've got quite rural practices, so there's limited AHP workforce in the PCN already, and we were the first ARRS, the first additional role reimbursement scheme service and staff in the practice. Obviously, we had the challenges of that, and of course there's competing priorities currently in the PCN and in primary care, and that's something that we all feel. Whether you're directly employed or hosted, but those are just some of the things to give you a bit of a sense of the landscape. So the support that we've sort of put in place in our service is we have a local FCP peer network group, which is an absolute lifeline. It's really, really helpful just to reach out and have that direct contact with other colleagues. It's certainly something I knew that I would miss, having come from a hosted FCP model previously. But also making a massive effort to get links with the local MSK provider. That's been an absolute gem when you can get it, and it's really important. It needs upkeep. That relationship needs upkeep, and also having that work with the ICS MSK educational leads, which we have in our area as well. And it's helped with things like CEPIC setting up induction, liaising regarding training needs, and of course that has a knock-on effect to the roadmap as well. In terms, we've got a GP educational lead, which is brilliant, and they help us access funding and support. Our GP mentors are brilliant as well, and there are now other additional role reimbursement scheme roles in our PCN, which is really great because obviously we have the similar challenges, but also similar successes, and can share the learning across the PCN. In terms of the roadmap, there are a couple of things that I wanted to share that I think has been really valuable learning for us. So I'm one of the supervisors for the HE roadmap in our PCN. So I've done the supervisor course. And I certainly say that there are a lot of things on the supervisor course that I had assumed from reading the roadmap, one thing, but actually under being on the supervisor course, it really gave me clarity on some of the things that I'd assumed were correct, and actually it really gives you clarity on how the supervision works and what the processes are. So I'd definitely say if you are not able to do supervisor training yourself, then speak to someone who has about what the process of supervision for the roadmap will be like. So we do have myself as one of the supervisors, but also, of course, I need supervision as well. So GP educators are able to be roadmap supervisors, and our GP educator is very happy to do that and has been on board with that since the beginning, really, since the roadmap was launched, which is fab. We do have job plans, so that includes CPD and admin time. That's probably going to change once we've completed the roadmap, but it's been absolutely critical to being able to plan for the roadmap, and I would certainly say that's something that needs bringing up with practice managers, with GP mentors, with PCN directors if you don't have CPD time currently, because that's where your roadmap work has to happen. We've done training needs analysis, which has been really helpful to indicate the areas that each of us will need support with, and funding as well. So that's been really good. But of course, that adds into elements of the roadmap as well. And then in terms of the supervision aspect of the roadmap, the daily debriefs is something that we've implemented that's been really helpful, actually. It's just great to touch base, whether that's virtual or face-to-face. With my mix of workload, I'm not full-time in the PCN, so that means that we do need a mix of supervisors. So I provide that daily debrief when I'm able to, but we do also have agreement with the GPs who will provide daily debrief when they need to, which is brilliant, because it's really good also to get that variety as well for the clinicians, that they get a different clinical perspective. And we also have a calendar of roadmap activities. That was one of the first things we implemented once we got to grips with the supervision elements, is actually how are we going to plan for the workplace-based assessments? And that's a variety of virtual and face-to-face planning. Obviously some of the things do need to be face-to-face, but it depends on what the makeup of your telephone versus in-person appointments are currently. But that's been really helpful, is to have that calendar, because we can then work backwards from what our aim is. So I would really encourage people to set some goals, set some dates, and then sort of fill in the gaps in between with your supervision elements, because that's something that you need to liaise with your supervisor about. And then also supporting each other has been so helpful. And I don't mean just within our practice. So obviously, the GP supporters, the Regis supporters, we support each other within the practice, other PCN, ARRS roles, so pharmacists, social prescribers, we all support each other, but also reaching out to other FCPs, so the FCP network, but also, a little wider than that, people that you come across, people you might have networked with previously, just reaching out is really helpful. It's helped us to think about the audit part of the roadmap, so actually how we're going to evidence our audit process, and sort of supporting each other through that. Sharing resources has been really helpful, because there are some things that some people find first, like some great resources on the landing page that have a Excel spreadsheet with all the elements of the roadmap that you're required to fill in them, and that's a brilliant resource. And it's through our networks that I first discovered that, which was great. We sort of do a kind of portfolio show and tell. It's almost like inspiration to keep each other going. What does yours look like? What have you been working on? And that's something that through my non-medical prescribing, which is also mapped to you have to do a lot of mapping and portfolio based, actually having that inspiration of how people have done it before. Some people do it in a Word document, some people do it on OneNote, some people do it on Excel, and it's really useful just to see people's different approaches to mapping. So, a bit of a show and tell of, what does yours look like now? How have you structured it? How have you all those elements, the practical elements of what it looks like is actually quite helpful. And then we also have a monthly roadmap catch up with our network as well. So that's any sort of tips and tricks people have come across, how people have been finding it, what support is there out there, how people are getting on with the supervision, any tips for preparing for the CVDs, things like that. And so we've certainly found that element of the network really helpful. So I suppose my biggest tips are to sit down with your supervisor and plan a calendar of events. So what do you need, both of you there, and when can that be done? And really make a goal for when you want to be completed. So we know that the deadline has been removed, but we still need to have an agreed end date. And actually it's really helpful to have that goal in mind, because then you can work backwards and fill in the blanks. And the other thing is really just to reach out. So within your PCN, so find your GP mentors, have that honest and frank discussion. I am going to need 5 minutes of your time at the end of the day. I'll make you a cup of tea. Let's have a catch up before we leave, because that's going to be my daily debrief. That's going to be really helpful to have that honest. I'm going to come and knock on your door at 4:30, because it may be that there've been some things that I want to discuss. That's the daily debrief. It's up to you to sort of take that responsibility to make sure that you've got that in place. Obviously your supervisors should be looking out for you as well, but they certainly are going to be happy if you can take that first step and take that initiative. So I think the calendar events, get your daily debriefs in with a variety of clinicians, that's absolutely fine. And definitely job plan your CPD time, because otherwise it can be really overwhelming. To have those discussions early if possible. And try and have fun with it, see it as once it's done, it's going to be a huge achievement. And the standard that we're going to be able to prove that we're at as FCPs is fantastic. What we certainly don't want is to be in a position where directly employed FCPs feel like they're the second cousins of those that are in the hosted model. We're all reaching to the same standards. And so, that's really where we have to step up and use the roadmap to show that we are at the level that we say we are. And that's what it's there for. So I think it's a really good opportunity, actually, to showcase what we can achieve in first contact. So thank you very much.
Thanks to Hannah for doing that pre-record, and I think a presentation full of really useful tips, some formal, some informal, in terms of how to manage some of the challenges around supervision and working as part of that primary care team and not feeling isolated. So we've come to the panel discussion, and I'd introduced colleagues before. Nick Worth is with us, Abby Henderson, Julie Blackburn, Jill Rawlinson. So I'm going to take some questions from the Q&A. Do keep putting them into the Q&A, and do remember to look at the answers and the other tabs as well to get your clarifications. Panel, I'm going to start off with just a general question, because I think this has caused lots of conversations over the last year or so. Linda posted this. What would you say the differences are between an FCP and a normal physiotherapist who works in a private MSK clinic? Who would like to give that a go? Nick, cheers.
Yeah, hi, I'm quite comfortable with this one. I think the key part of that question is the private MSK clinic. I think what you're looking at is, if you're a physiotherapist that's a private practitioner, what you're doing is you're going to be expected to see someone who, agreed, may come off the street, but then you're going to plan the whole treatment and management from them every step of the way. You're going to be the one that's going to do the rehabilitation. You're going to be the one that sets the exercises, potentially manual therapy, strapping, everything like that. You're taking them through all of it. As an FCP, you're there as the signposter. So basically, that's within a GP practice or similar sort of position. What will happen is they would see someone, and essentially you're the signpost to send them on their way. So you probably would only see someone once, maybe twice, because if you're going to be regarding them for physiotherapy, you're going to refer them on to the physiotherapy service within that area, or you're going to recommend them to have some sort of imaging. There could be watch and wait. So the difference is, as a private physio, you're going to take someone all the way through those steps. As an FCP, you're the signposter, and you might be seen at sort of people before they know they've got something musculoskeletal. It may be a pain, and you're going to be the one to deal with those complex issues.
Nick, and would you also think it's fair to say that one of the differences, obviously, with the roadmap is, if you're working to the roadmap, it provides explicit and transparent standard in terms of the education level that you'll be working at. And so one of the really positives that I kind of heard, particularly from you, was around being able to reflect. This isn't about just one moment in time when you've done that course. It's about that ongoing reflection on your practice, the level of your practice, and therefore what it's contributing. Yeah.
Absolutely, it's that consistency. So it's not good enough. You know, I see that, obviously, and one of the things with people who've been doing this job for a long time or working in these areas kind of go, well, I did my master's years ago. Isn't that enough? Well, how does anyone know that you're still working at that level and you're still competent in all areas? And it's an ability to then say, do you know what? I am working at this level, and I can satisfy these 4 pillars all the time. And that's where it's about. It's about proving to yourself that you are safe, competent, and capable of doing the job.
Yeah, great. Can I just follow on with a question as well from the Q&A? Will colleagues currently, and we're talking about physiotherapists, I think, who've worked for a number of years, who've been working at ACP level, but have less qualifications, and I'm assuming that means formal qualifications like masters, etc., than someone with a master's, for example, now be required to undertake the roadmap? Quite a fundamental question. Yeah, Jill, just speak up, Jill. Slightly faint.
Yes, can you hear me?
Yeah,
okay.
Perfect, thanks.
So I think it's really important that if, I think that's supposed to say ACP, isn't it?
Yeah.
Or Advanced Orthopaedic Practitioner, I wasn't sure. But I think it comes down to this working at that level. I think if you're working at that level, then all of the knowledge, skills and attributes in both stage 1 and stage 2 well, certainly stage 1, you should be able to demonstrate. The roadmap is about applying this at stage 2 in primary care. So I think you're only going to need to do the roadmap if you are going to be wishing or working in the primary care environment. There is work in development to look at this, the MSK advanced practice standards for all practitioners from all professions working across the MSK sectors, secondary care and other environments, that will have a whole set of standards across all 4 pillars that will be required to evidence to join the Director of Advanced Practice. But I think, to be in answer to your question, I think you only need to do the roadmap if you are in primary care. If you are in primary care, even if you're working at advanced level, I think the thing to say is if you are working at advanced level, then you should easily be able to demonstrate through a range of pieces of evidence, as Nick's illustrated, that you are working at that level. And it's a real opportunity to demonstrate that you are at that level. So I don't think people should be afraid, because if they truly are working at advanced level across all 4 pillars, you should be able to bring in lots of examples to do that. And I think that advice about not rushing and taking your time to think creatively about the experiences you've had. So you might not have done a formal master's, but there's something about how you demonstrate thinking at level 7. And it may be that you see there's actually a gap, that perhaps some formal study at level 7 might be something that is useful for you, perhaps in leadership or research, for example. So I hope that helps.
Yes, Sue, could I just come in just briefly as well, just to say as well that just be really clear that this isn't about a qualification. This is about capability and skills and capability in practice. So whether you have an AP or a master's, if you're working in primary care, you will have to demonstrate the knowledge, skills and attributes required by the roadmap. So I think it's just to be clear from that question, I wasn't clear whether it was thinking that if you had a master's, you didn't need to do it. I think there's been there is a criteria for the supervision course, is that you do need to have a master's level.
Thanks, Abby, for that. Panel, just to flag up, I'm going to come to a couple of questions about hours and resources in a minute, but I just want to pick up something, and thank you, Linda, for putting this in the chat in response to our first question about the difference between your normal private MSK physio. I think, in short, we are really concerned about the standard of education training, the standard of practice in every sector with every individual. And so it's not that we're not, but I suppose it's the reach and how we set those standards and how people engage with them. So there are a couple of pieces of work in the pipeline that will be coming out later this year around MSK standards for any service in any sector. And so there will start to be more of a focused infrastructure coming out for all sectors, but it will obviously be up for individuals across the board to engage with this infrastructure and with those standards. So we are concerned. So panel, just coming to Ewa Craven's question in the Q&A, if the supervisor is not from an employer or PCN, how is their time resourced and does the employer need to pay? Who would like to answer that?
I can come in.
Go on, Abby.
Sorry. So I was just going to say, I think this is probably one of the areas that's still a little bit unclear and probably quite regionally and locally variable. So we are hearing sort of different things being agreed in different areas. So for example, in some areas, there's been some innovative work being done from the local training hubs to be able to support some of this work. In other areas, they are coming to sort of service level agreements with other local supervisors. I would say it's still quite early days with this sort of work. I don't know whether Nick can add anything, but what I would say is that we as a CSP would say that no individual who is employed should be paying for their own supervision. And that's very clear.
Yeah, the one thing I would agree with what Abby said there. Yeah, it should be. What I think we really are at the start of is we are in the start of a culture shift, because everyone should be receiving support and supervision under normal circumstances, whichever sector of healthcare you're working in. But it is unusual for AHPs, whereas GPs and doctors often get that as a standard. It's new for us. So at the moment, lots of people are going, well, who's going to pay for it? How's it going to work? Well, what we'd like to try and work towards is that becoming the norm for everyone. But we're at that stage that people are asking questions. Hopefully in a few years' time, we'd all be receiving a certain amount of supervision, support, whatever you want to call it. And that's just part of our normal contract. But we're starting to turn the tide there.
And I think just remembering as well that GP trainers can be supervisors. And I think that we're hearing from quite a few directly employed members that actually that's probably where they're going to get their supervision from. So it's probably, as Nick said right at the beginning, it's about starting those conversations with your employer about identifying where supervision can come from within your primary care team or your PCN more broadly.
Thank you both. Can I just come to a couple of questions? There's something in the chat as well as the Q&A from Alison. So a couple of questions, and Jill, I was going to come to you if you could come in on this. How many hours have people been given for their roadmap work in a normal working week? And then from the chat, somebody was asking how much CPD time others are scheduling into their diary, and obviously wanted to know from peers. But Jill, I just wondered whether you could say something about hours for CPD for meeting the roadmap.
I think Abby might be better placed to answer this, because I know you've been looking specifically at like the templates or clinics, or do you want me to come in?
Yeah, no, I'll start, and then Jill, if you like. So, so I think this is a much broader thing than just the roadmap. This is about your job plan that you're working towards day to day, day after day, whether there's a roadmap or whether there's not. There is absolute clear guidance from NHS England about job planning and how important it is. And we certainly see that from an FCP perspective, and particularly if you're working in FCP in full-time roles, which more directly employed FCPs tend to do than those who are on the host model, the host FCP model. So it's been really clear about what your needs are, and your job plan may look different to a neighbouring FCP's job plan. Should be individually determined. This might be around your level of experience. So someone who is new into FCP may need their job plan to look different, and so this is about coming to that local agreement. But what we are clear on is that no FCP should be working 10 sessions a week clinically, as in all that time with in-person or virtual consultations. There does need to be time agreed for admin. There needs to be time for CPD. And there is, I'll pop a link in the chat in a minute, but there is job planning guidance, which is absolutely transferable to primary care, obviously in a different context. So certainly the Health Education England have talked before about sort of an 80-20 split. But without dictating exactly what that 20 looks like, but certainly that would seem a reasonable amount to go for sort of an 80-20. But bearing in mind, you may need more at particular times. You then may need less. But I think it's really important to think about your CPD overall, not just about the roadmap. The roadmap is really important right now, but there is something about developing you as a clinician as well. So taking it all into account, but having those really open conversations with your employers are really important.
Thanks, Abby. Can I just go for a quick comment from Nick? We've got a question about, does the debriefing that I think Hannah referenced need to be formal or just an informal chat during a tea break, Nick?
It's about a mixture, really. It's about the fact that you can have daily debriefs that could be having a cup of tea in the middle of the day. What I would say, though, is not to underestimate these. These are an important part of supervision. Now, they shouldn't be the sole part of your supervision. That on its own is not enough. So yes, they can be, but it might be that once you've done one of these daily debriefs, you reflect on that, maybe making a couple of notes to sort of find out what complex cases you were talking about where you do things differently. So yes, you know, tea break type chats are valuable. They can be formal, but it's about having a range of supervision to support you that's important. But don't underestimate them and just think they're nothing because they're just a cup of tea. It's actually the stuff you're talking about there can be just as important as doing a learning needs analysis. It's just about how you put it together and then reflect on that and use it as part of your portfolio or evidence.
Thanks, Nick. I can't remember which panel member said about the locally agreed deadline. Abby, was it you for stage 1? Can you just clarify that for Rowena, please? What did you mean by locally agreed deadline?
So this is about the guidance of the April 22 guide has been lifted. And there is guidance out now from HE that best practice is to do it if you're in a full-time role, to complete stage 1 sort of from now, and then work on stage 2 within 6 months of your completion of stage 1. And I think what we're saying is that, as Hannah alluded to talked about in her video, is that having an agreed deadline is really important for you to be able to plan this in. It's exactly taking into account what Nick was saying about not rushing it, but having some idea of where you're looking to work towards, so your employers understand as well what your level of need of supervision, etc., is going to be. But if we just leave this open-ended, there is the sort of risk it gets deprioritized with the busyness of work, and exactly as Nick said at the beginning of his presentation, this is really important. So, you know, we as a CSP, we're really pleased that deadline has been lifted, because we do think that there is, that it was really difficult for members, but actually we're still saying you should be having conversations with your employers. You should be thinking about what factors there are to determine your deadline. So you should be looking at, what else is happening. Do you have a supervisor? Do you have you got that job plan agreement with that level of CPD time? And if you've got that in place, there is no reason to not just sort of crack on and get on, just get on and move it. But if you're struggling with those things, then you may need to give yourself a little bit longer, but just have an idea of what you're working towards.
Thanks, Abby. Thank you. Jill, I wonder if you can answer, where do current advanced physio practitioners who do not necessarily take part in research and audit, but cover the other 3 pillars stand, i.e. an MSK service, as you're not an FCP, but may not necessarily cross all 4 pillars?
Yeah, certainly. I think if you're working at an advanced level, there should be, really, you should be working across all 4 pillars. And I would often challenge that you likely are. And I think it's about identifying what each pillar means and perhaps not thinking of them in as very discrete entities. So you don't have to be doing research directly or even audit, but it's about understanding evidence-based practice, actively embedding it in your practice on a daily basis. Perhaps if you're collecting data, which you should be as part of your outcomes for your patients and service, you're likely to be using that. So I think this is a really important point about how we view the 4 pillars of advanced practice and how we need to see them as a sort of intertwining helix, if you like, that we embed in everything we do, rather than perhaps thinking of them more distinctly. So I would absolutely say if you're going to be working at advanced level, you will need to be able to demonstrate. But I think go back to the multi-professional AHP framework and read the research capabilities, because I think they are broader than perhaps some people acknowledge. And then the second thing is just to think about ways that if that is an area that you need to develop, that you might be able to get involved in a little bit more service evaluation, quality improvement, audit research, because it is absolutely integral as a registered practitioner that you're doing that anyway. So yeah, and I think it's the same with the education pillar, taking students, pre-reg students, really important, teaching others, thinking about the pillars in a very dynamic and interrelated way is what I'd advise.
Thanks, Jill. Sorry, I've just lost the question I was going to ask the panel now. Yeah, a question from Susie. Is there no way of demonstrating you're at the advanced level to go on a supervisor course without a master's? So done models such as injection therapy at master's level already, but not a full master's. being expected to mentor supervise new FCPs, would like to do a supervisor course that doesn't have a prerequisite. Is that possible?
I'll answer this one. At the moment, as I understand it from Amanda Hensman-Crook and Julia Taylor, it's purely, this is a way of just starting things off. And literally, this is where they've said a postgraduate master's gives that start point as a level of whether it's a qualification or academic ability. It's not dismissing what's gone on before, and maybe there will be an evolution of this, but it was just as a start point. That's how they did it. There was some confusion about whether a pre-reg master's would count at one stage. So if someone's done a number of master's level modules but hasn't put them together in a master's, my kind of conversation would be, you could do, and you could achieve that. Alternatively, it's about being able to say that if you're a supervisor, that you are at a certain level of competence, and it's a start point, but hopefully things will evolve as time progresses.
Thanks. Nick, I just wonder, the third question down about 12.12 and 12.13 at the end of the roadmap about the domains and competencies. I don't know whether you can answer that online. And I was going to ask the rest of the panel about Sarah's question from a PCN point of view, looking at directly employed versus third-party provider FCP. Any thoughts on this panel regarding clinical supervision within practices? Abby, do we have any examples that we can point to around this particular issue?
Well, sorry. So I think it's just from reading that, a bit sort of asking, is there any perspective on, I suppose there's pros and cons to both, isn't there? I think we would say from the CSP that our perspective is always that actually, we want integration within the MSK pathway, and that can be challenging for some independent providers, third-party providers to get that. Not to say it can't be done, but that can be challenging. And this is linked to that because to be able to demonstrate the roadmap is about being able to know your links. Part of it is about knowing your links with your local pathway, to know what to do with masquerades, etc. So I think it's very much looking at what for me, it would be, if I was a PCN, I'd be looking at what's your capacity within your PCN to provide that level of support for an FCP, and just looking what sort of offer is around. I think the only thing I'd say is that even if you got from a third party provider, there is something about, we need to be clear that these FCPs are a part of the primary care team. You are not about going in, doing a job and leaving. So whoever your employer is, you need to be embedded within the primary care team. And that came out as part of our phase 3 evaluation quite strongly, that actually that's really important for FCP satisfaction, for lots of reasons. So I don't think it is as simple as sort of saying, well, if we get a third party and they'll deal with all of that supervision, because actually there is something about needing that day-to-day support and links in with the GP, exactly to have that open door policy. So the GPs, no matter how it's contracted, as it were, those on the ground in the GP practices need to still have some responsibility and accountability for supporting the members of staff who are working with them, no matter who employs them, would be my perspective.
Thanks, Abby. Nick, I'm going to ask Abby, you to come to the top question in the Q&A, first of all, that Linda has asked. But Nick, I just wonder whether Linda's next 2 questions, whether you could also start putting some answers up. We're just running towards the end of the session, but I just want to make sure everything's answered. Would that be okay?
Well, so do you want me to type them in?
Would that be okay while Abby's
no problem.
giving a go at the first one? So, Linda, you're saying that you luckily got to skip stage 1 due to holding the MACP MSc, but your network are thinking about employing another FCP or a paramedic, and they're confused about how to move forward, as prospective employers will be required to complete stage 1 before entering primary care, ? I know currently there's no leeway for FCPs already working, can do stage 1 prospectively, but what about going forward?
Yeah, so again, I would say this is an area that we don't quite have full clarity on. I think it is about going back to what Nick was talking about this is about demonstrating capability. And of course, what we want is we don't want clinicians in primary care for 6 months, 9 months before we know that they are capable and competent to be there. So this is about working towards being able to get clinicians on the ground who can demonstrate that capability straight away. But of course, there is this sort of bit of interim space where that's not quite ready yet. So I think there is something about being pragmatic, but I would also say that there's an awful lot of stage 1 that clinicians can do independently before they need that supervisor. So they can do the e-learning modules, you can start the mapping, and then use, try and find that supervisor either through a primary care training hub, or it depends on where you're at really with your employee offer. There are some employers will offer to support you through that stage 1. So there's it's a bit variable really, and I think there isn't a clear answer just yet. I don't know, Nick, if HE have got a position really about that stage 1 bit yet.
No, it's that kind of range of resources that are coming out, and it is. The big thing is, like I've said quite a bit of the time, it's about that evolution over time. As more people go through the system, at the moment, the registry is not public facing. We were hoping it would be by this time, and it isn't. When people have gone through it, then we'll have the experience and knowledge for them to become supervisors and then supervise again. And so it is a continual process. But at the moment, yeah, I agree. I'd want a lot more resources out there than are there now. But over time, that will start to be collated, I guess.
Thank you. We are really pushing it against time. And Nick, I know you were just getting back to Linda's last question. Can I just point to the chat? Because if you have further questions, please do contact us via email by the fcp@csp.org.uk email, and we will answer questions. But May, can I just ask you to post the final poll, just so we get an idea of whether this has kind of hit the spot for you?
Sorry, this one first is about when people think they might complete the roadmap.
Thank you, May.
Again, it's just anonymous. Just leave that for a couple more seconds.
Thanks, May.
And then, yeah, the last one is just following this webinar. It's sort of a follow-up on the first question. So whether your confidence has now increased following the webinar.
Please be honest.
I'm pleased to say, yeah.
Yeah, please do be honest, because if it hasn't, then we need to do more. So, and if you're not confident, please do put in the chat any sort of final remarks about what you still feel that you need.
So can I just comment? There's the one there just about the concerns about masters.
Yeah. Do.
Is that okay? Just to say, I would, whoever that is, I agree with you. I agree that there is a real mix of people that have a lot of experience that haven't got masters, and some that haven't, that are not so good. It's a start point. So I agree that there will be a vast number of entirely capable and fantastic clinicians that haven't got a master's. It's just difficult to know without evidence as to where they are and what they are. And this is a start point. So don't be too worried about it. It will evolve over time. And if you are an experienced clinician, you'll get, recognition for that via doing your evidence. It's a process, but don't worry about it. No one's penalizing you. It's just starting from nothing, has to start somewhere. That's all.
Thank you. And just final question, May, from the poll.
Oh yeah, I've done them all now, sorry.
Had you done the third one?
No, we only had two more.
Oh, sorry, I have 3 on my list, apologies. Okay, so lots of resources and links in the chat. So I hope people have cut and pasted what they needed from that. Do get back to us on the FCP email if you've got follow-up questions. I'd just like to encourage you all to keep on with the challenges that the roadmap's setting, and just try and reflect on and absorb everything that's in the presentations, and get in touch with us if you need further specific help, or indeed your regional HEE links as well, or faculty leads. Thank you to the panel, to Abby, to Nick, to Hannah in her absence, Julie for supporting us, May and Jill, and thank you to you all for attending. Have a good rest of the evening.